My name is Joan Reed. I'm Dean for Diversity and Community Partnership, and I want to welcome you to our 7th Equity and Social Justice session in this academic year. And today's topic is Your Leadership Voice, Challenging the Narrative on Diversity, Race, and Health. I'm pleased to see so many students and trainees and staff, faculty from across our Harvard community and our neighboring community members. Our Equity and Social Justice series includes lectures and seminars and opportunities for dialogue around issues that impact the health of our nation, the health of our communities, and really focus in 4 areas: in history and context, culture and environment, health disparities, and leadership and skills development. And our speaker today actually touches on all 4 of those areas in terms of the work that he's done in his career and understanding the importance of our history and context and culture and environment and how it shapes who we are and what we do, and his impact on health disparities, and our shared commitment to this importance of leadership and skill development for people who will replace us in some ways in the future. Not now. We're going to wait a little bit. But Dr. David Hayes-Bautista is the Distinguished Professor of Medicine and Director of the Center for the Study of Latino Health and Culture at the David Geffen School of Medicine at UCLA. He graduated from UC Berkeley and completed his doctoral work in basic sciences at the University of California Medical Center. He served on the faculty at the School of Public Health at UC Berkeley until 1987, when he took his position at UCLA. His research appears in a variety of medical journals, from the American Journal of Public Health to Salud Pública de Mexico. I like trying to say things that I don't say well, but I try. I try. Some of his published books include The Burden of Support, Young Latinos in an Aging Society, and El Cinco de Mayo, An American Tradition. He writes columns for the Los Angeles Times and La Opinión. And he's asked to provide his opinion and his perspective on many radio and television talk shows in both Spanish and English. For the past 5 years, he's been chosen one of 101 top leaders of the Latino community in the United States by Latino Leaders magazine. And he received the Herbert Nickens Award from the AAMC, Association of American Medical Colleges, for his lifelong concerns about the educational, societal, and healthcare needs of underrepresented groups. And another award, the Oatley Award from the Mexican government. He is a very good friend, an amazing researcher, and someone who's deeply committed to issues of equity and social justice. And with that, Dr. David Hayes-Bautista.
Thank you, Joe. But really, I'm just a nerd. But that's important. That really is important. Because if there's diversity in the research team, but that diversity has not found and developed its voice, that leads to bad science. I'm a nerd. I'm a scientist, basically. This is now the most important thing for us to understand as we go forward in our careers in science. So let's just talk for a minute about an issue in science: artificial intelligence and these facial recognition programs. How many of you have an iPod 10 with the face recognition? A couple of people. Okay. Well, actually, my brother-in-law teaches AI over at MIT, so he's been telling me how this works a little bit. What you do is you develop a neural network that's going to sort of function kind of like the brain does. Rather than writing a program, it's going to learn how to do things just kind of the way humans do. So you input the world, this neural network learns it, and then things can happen. And this is fairly simple. This is just facial recognition. But something happens. Facial recognition programs work really good if you're a white guy. In less than 1% of the cases will the facial recognition assign the wrong gender. Now, if you're a white female, in 7% of the cases, the program will say, we'll give you the wrong gender. If you're a dark-skinned male, in 12% of the cases, it will give you the wrong gender assignment. And if you're a dark-skinned female, 35% of the cases, you'll be given the wrong gender assignment. Now, this is science, right? But why would a facial recognition neural network produce a 1% error for white guys and 35% for dark women? Just why? Yeah, the world that neural network was exposed. This is the world that they know. It works perfectly well for them. This has a term. It's called code bias. That, in fact, that biases that the programmers and the developers just unconsciously hold, because this is what they expose these neural networks to, seep into the artificial intelligence programs. Seep into. Well, when I read this back in February, I thought, that's interesting. Let me try this. And you did something similar, Joan. I came out from the AI side. Yes, okay, so let's talk about the search engines in Google. So I Googled, here, doctor sitting at a desk. Here's what I came up with, first page. Code bias? Okay, so I thought, okay, well maybe let's try pediatrician. All female. Code bias? These are search engines, okay. Well, actually, there is a similar sort of code bias in our current narrative on diversity, race, and health. The way we do the research has built-in code bias. The way we create our policy and our programs. Here's a prime example of this code bias. This came right off the website of the Office of Research on Minority Health. And it says, African American, American Indian, Alaska Native, Asian and Pacific Islander, and Hispanic citizens. Now, on the West Coast, that's a whole bunch of folks, okay? Suffer poorer health and higher rates of premature death than the majority population. I'm sure you're familiar with this. You were probably taught this in your classes. We can update to 2014. The recently released Centers for Disease Control and Prevention report, Health Disparities and Inequalities, demonstrates that African American, Hispanic, Asian American, and American Indian and Alaska Native populations suffer higher mortality rates than other populations. Let's unpack. For me, I see the code bias in this. There's tremendous code bias. So let's unpack this and let's use some data. So let's start with the current narrative over here to the left. In the current narrative, diversity in the population means dysfunctional outcomes. I mean, we just saw some of those statements. Here's another one, a more recent one. People of color are more likely to live shorter and sicker lives and are less likely to survive a host of chronic illnesses. Again, you get this in your classes. Second code bias, the social determinants of health. They are obstacles to good health. Institute of Medicine, in its recent report on metrics that matter, health disparities across neighborhoods exist for a variety of reasons, including education, income, we have heard that, and race. Poverty is a form of income. Education, income, and race. Those are social determinants. And in this code bias narrative, well, until we can erase poverty, increase income, increase education, build stores and food deserts, restore housing, there's no way these populations are ever going to be healthy. Whew, that's a big task, and I'm just a little community hospital. How can I possibly do that? I guess I can't do anything. In fact, let's talk about race for just a minute. These are my terms. When we talk about race in our current narrative, we are using, this is my term, the hard-edged U.S. binary. The hard-edged U.S. binary, you see in the tables. Here's a typical table. These are births in California. Here are the white births, Pacific Islander, Hispanic, Black, Asian, American. Isn't it neat how everybody just fits into one of these categories? You're either here or you're there. And then they all add up to the total. This is the binary. Hard-edged. You must be either here or there. So this is how we do our research based on these assumptions. In fact, just recently, this is right out of IOM, Joan. This is their report about a year and a half ago. Race, down here, is considered an innate individual trait. It is something you are born with, innate, and it's in you. So I've been wondering, as I look at this hard-edged U.S. binary category with race being an innate characteristic, how do we operationalize this? What makes, for example, in this society, a non-Hispanic person white or black? Well, up until 1980, the census didn't ask you what race you were. You probably have all grown up responding, saying, I think I am X, Y, or Z. Up until 1980, the enumerator looked at you and decided what race you were. Did that from 1790 to 1980, almost 200 years. And here are the instructions to the enumerator for the 1930 census. A person of mixed white and Negro blood was to be returned as Negro no matter how small the percentage of Negro blood. That's on that famous one-drop rule, hard-edged binary. Now, you've all taken Chemistry 1A. Remember when we looked at solutions and concentrations? Okay, so you have 30 gallons of water. You put one drop of iodine in and suddenly the whole container is iodine? Well, in the hard edge, it's saying, yes, yes it is, and you must be over here. You can't be over there. I just want you to keep that concentration and solution picture in mind. But as I look at that, when the enumerator was determining who was black and who was white, was that science? Or was it operationalizing the local racial narrative? Okay. Well, let's take a look at how we do this. This is in the 2010 census. These are the race categories that people are given. You can be white or black or American Indian or Asian, Indian, or Chinese, or Filipino, Japanese, Korean, or Vietnamese, or some other Asian, or Native Hawaiian, or Guamanian, or Samoan, or some other Pacific Islander. And as you look at the non-Hispanic population, after 230 years, pretty much people have got the drill. So as you look at non-Hispanic respondents in the 2010 census, pretty much white folks said they're white, black folks said they're black, Indian folks said they're Indian, Asian said they're Asian, Pacific Islander. Very few said, I don't see myself. I'm either some other race or I'm two or more race. Very, very few, rounding error. And they're usually withheld from analysis. Too complicated, don't really upset the entire scheme. Now, when we do analysis, usually we know what units we're dealing with. For example, here we're doing some regression analysis on education. Well, education can be defined a lot of ways, but you know, you went to school, you did something, either for X period of time or you earned so many units. So here it's years of education. Actually, they lump them. Less than 12 years, 13 to 15, it's 16. But everyone agrees a year of school is a year of school. Likewise, income comes in dollar amounts in this country. And we know $1 is different from $1 million. Here they've stepped them by $10,000 increments or above or below poverty. But we all know a dollar is a dollar and a dime is a dime. There's no question. Then, just as simply, we plug in race. Here we're going to regress on white, black, Hispanic, and Asian. Just as if they were years of school or dollars of income. And then we get our regression equations, and here are coefficients, and we've done science. I want us to challenge that. But we need your voice. I'm talking about Joan and me. We need your voice to develop and walk into the research labs and say, wait a minute. I can suggest better science. And it has to do with types of leadership. There are a couple of types. There's the type that I grew up with right after World War II, which is command and control. You're too young, Joan. You didn't grow up with this. It came out of World War II. You know, the way like the military, where you have one person at the top gives all the orders and everybody just fulfills them and salutes and they go off and do it. That's the old style of leadership, although we have somebody in the White House who thinks that's still the way it works. He's learning it isn't. Okay. There's a different style. It's called transformative leadership. This is very, very different. In transformative leadership, everything starts with the person, not necessarily the CEO or anybody in the C-suite. Anybody can exert leadership. But first of all, the very first step is to lead yourself. That requires self-awareness. Once you lead yourself, you can then lead a team. Then you can change the world. But it all starts with self-awareness. Who am I? What am I trying to accomplish? It's called Transformative Leadership. I call it leadership from below. And as I look at, say, the Chicano health movement, the African American Neighborhood Health Center, this was leadership from below. It didn't come out of the White House. It came from below. So here we have the situation. Just anybody could actually be a leader. All it takes is challenging the process, looking at how business is done, whatever it is, and thinking, things could be done better. They could be done differently. But I'm just a grunt. Well, that doesn't matter. Because what you do is you inspire a shared vision with your teammates. Not telling them what to do, create a vision that's so compelling, everybody says, yeah, I want to do that too. Then you empower them. Empower them, not you. You empower them to achieve that vision. That's modern leadership. It's very different from what we have in the White House. Very different. And the way you do this is you find your voice. You may have heard that in the leadership literature about finding your voice. It's so important. So let's talk about voice. In Transformative, it's not shouting louder, it's finding the voice of who am I and what do I want to accomplish in this world. Sheryl Sandberg said this voice comes from bringing your whole self to work. That's really important, be able to bring your whole self. The problem is that it requires that you have a whole self you can bring to work. And here is where there is an important barrier that many people here have got to deal with that keeps them from bringing their whole self to work, the imposter syndrome. I think we're pretty familiar with it. Here, Maria Klaw, who one of the best researchers I've ever known, highly decorated, finally said just recently that she would like at the beginning of every STEM course, the instructors talk about the imposter syndrome. As she said, like many other women in STEM careers, I suffer from this myself. And of course, at universities, in graduate school, and in medical school, particularly a lot of women and underrepresented minorities carry around this imposter syndrome. I don't really belong. Man, they had better OChem than I did. I didn't get to go to Europe for vacation. I had to help my parents. You know, I don't belong. The imposter syndrome. And a recently commissioned study, the author, Joyce Roche, came to the conclusion that imposter syndrome is surprisingly common among some of our most successful African American and minority leaders. It's also common among women. So finding voice is the first step in battling this imposter syndrome. But Latinos get an additional syndrome. An additional syndrome. And I'm going to share my experience with this. I was born in California. This is me in high school. Wasn't I cute? About 50 years ago. Okay. At least I still got my hair. And all my life, I'm kind of tall, kind of dark. All my life I've been asked, oh, so where are you from? I'd always say, oh, no, from here. Well, what do you mean from here? Yeah, California. Really? Where were you born? Los Angeles. Really? Yeah, really. So where's your family from? California, Arizona, Texas, New Mexico? Like they weren't believing that I'm really here. And then finally I would get, and you may have gotten this, so what are you? What are you? Well, at this age, I would give an answer, but because I had not found my voice, no one would believe it. And I didn't even really believe it, because if nobody else believed it, why would I believe it? 65 years later, I give the exact same answer, but I have found my voice, and it just drives my research, my theoretical development, my data acquisition. So the content was the same. What changed was me, my voice. And what I respond now is, I am an 8th generation American of Mexican origin. My family has been in this country for over 300 years before this country even existed. People say, wow, 300 years. How did you learn to speak English so well? Oh my God, you can't win. Okay, so this is part of the imposter syndrome that Latinos got to deal with. We're too Mexican to be American. Oh, but it gets better. Then I go to Mexico, and I do a lot of work in Mexico. Same thing. Oh, you speak horrible Spanish. You don't know the history. Oh my God, you're behaving all wrong. You're not Mexican. You're too American to be Mexican. Okay, here's like the double imposter syndrome. Are we imposter Americans, imposter Mexicans? You know, just where were we in all of this? Okay. Well, that's why voice is so important. And thanks to the voice and the leadership that I sense developing here under Joan's guidance, biomedical research will enjoy better science. So let's get to the science, bringing your voice into the research lab. Let's go back to this narrative and let's reframe it with some data. Okay. So, what we're saying, from our experience in a group I have from UCLA Drew and White Memorial Medical Center, is diversity does not mean health dysfunction. So let's look at some data. Here we have some health outcomes, age-adjusted death rates, life expectancy of birth, infant mortality, the US and California. And you notice that compared to the United States, California has a much better profile. Much lower age-adjusted death rate, close to 20% lower, about 2.5-year longer life expectancy, lower infant mortality. Man, California does pretty good. That's the California profile. But California, 62% of the population is race ethnic minority. But it can't be a minority when it's 62%. That's close to a super majority. But we call it minority. You know what I mean? Okay. So wait a minute. How can California look so good if it's 62% racially diverse? Well, it's because diversity is not dysfunctional. In fact, Latinos, Asian, Pacific Islanders, and American Indians drive California's healthy profile. Those groups have lower age-adjusted profile than non-Hispanic whites in California, longer life expectancy than non-Hispanic whites in California, and lower infant mortality than the US norm. I showed some of these data at a conference 1.5 years ago, put on by NIH. I had 3 NIH directors. One of them, at this point, his jaw dropped. I've never seen those data. Where did you get them? Here were data. I get them from the National Center for Vital Statistics. But their narrative is so strong, they don't see the data. And that is bad science, very bad science. So diversity drives the state's health profile. It's not the problem, it's the opportunity. Now let's look at social determinants of health. They're always being given as obstacles. Maybe we need to understand, then, we need to explore the facilitators. What are the things that make minorities so healthy in California? Remember this? People of color, more likely to live shorter and sicker lives, less likely to survive a host of chronic illness. I don't see that in the data. So let's take a look at some other, the social determinants. Here now we have uninsured, percent below poverty, percent didn't graduate from high school, the US and the norm, and California. You notice California has more uninsured than the US, more in poverty, more that didn't graduate from high school. Oh yeah, wait a minute, didn't they have better health? Yeah. But they don't have insurance? They're poverty stricken? Didn't graduate high school? Yeah. Well, how is that? So let's take a look at the data. Because again, the narratives are so strong, we just automatically assume. In fact, what we're noticing is that individual poverty and income level, education levels, have no predictive power for Latino birth outcomes. We're going to look at birth weight just here. We can look at everything. What we're going to do is look, and we're going to do regression lines between white, African American, and Latino for 6 years, 2008 to 2013. So here, for example, we have non-Hispanic white at about 10% poverty. This is really tightly clustered. You know, if you're a stat nerd, you love this. And at about a little over 6% low birth weight. Good anchor. Here is African American, higher poverty, higher low birth weight. So you lay in your linear regression line. This is pretty nifty. It's pretty good, pretty robust. So according to this, you could predict that if a population is at 20% poverty, it should have 8% low birth weight, 30% poverty, 10%. I mean, this is almost picture perfect, right? So let's add in Latino low birth weight. Oh, lay in your regression line. No predictive power. Didn't predict a damn thing. Wait a minute, isn't it supposed to predict? Okay, that was poverty. Let's look at education. So here's the percent that didn't graduate from high school. Wow, look at why it's so tightly clustered. It looks like splitting the bullseye. African American, about 10% not graduate. Fairly tightly clustered. Again, really robust predictor line. Lay in Latino, didn't graduate from high school. Oh, oops. Negative predictor. A little bit. Basically no predictive. We have been told that until we can eradicate poverty and low education, minority groups will never achieve good health. I beg to differ. And that's 250,000 births every year for Latinos. So we're looking at close to 1.25 million births. This is a pretty robust finding. So actually, I've been looking, okay, well, something is going on that seems to be good. What is it? What are the social determinants that facilitate good health? Yeah, have they ever talked about looking at that? No, because we're always a problem. Diversity is always a problem. Nobody ever looks at diversity as an opportunity. Narratives. So to make a long story short, as we're looking at this concept has come up to try to explain, well, how do Latinos get these good birth outcomes? It's called the barrio effect. Now, this is frailty, breast cancer, and barrio advantages. They started noticing this, by the way, in the birth outcomes, that for Latinas, and it started in New York, some my colleagues researching this in New York, that the predictor for Latino bad birth outcomes wasn't individual level income or education or access to care. The best predictor was, did they live in a densely populated Latino barrio? And if they did, they had excellent birth outcomes, irrespective of individual income or education or access to care. The further away they lived from the barrio, the worse their outcomes, irrespective of individual income, education, access to care. The barrio? That has actually a good outcome? Apparently it does. Way on beyond the individual level predictors. And they're seeing this in a lot of different areas, in breast cancer, cardiovascular health, birth outcomes, fall risk, sex practices, mental health. The barrio is good for your health. And 99% of the faculty at David Geffen wouldn't drive through East LA with their windows rolled up with this, an armed guard beside them. Oh my God, they're going to carjack me, it's dangerous. Not if you want good health. But we need to understand what goes on in a barrio. We're talking now about a community, networks, life, demography, culture, history. And we don't study those when we do health. What's the income level? What I hate, the California Endowment does this a lot. Tell us your zip code and we'll tell you when you die. You've seen that. That'd be an easy one for some dissertation, or just blow it out of the water. Use data. And we see some similar things in African American neighborhoods, the good and the hood. For example, how do you decrease blood pressure in African American males? Well, if they go to an African American barber, their blood pressure goes down. Gee, what could that be about? And William Julius Wilson's all the stuff about urban underclass and everything else. Now researchers are discovering that if a kid doesn't have a father in the household, if there are fathers in the neighborhood, that has the same effect. The good in the hood, the barrio effect. But are we even aware of this in medical research? We already know the answer. They're minorities. Now let's get to the fun part. Race. And these are my terms. The U.S. hard-edged binary. Just race is natural. Didn't God make the races? Okay, no, this is a hard-edged binary. There's an alternative narrative. I call it the Latino fuzzy-edged multivalent. Multivalent, you can be a lot of things at once. Fuzzy edge, and it's not really clear where one ends and the other begins. That's a different algorithm. So the question comes back, okay, so what race are Latinos? Well, this all goes back to October 11th, 1492. On October 11th, 1492, not one single Indian lived in the Western Hemisphere. Not one. Oh, we had a lot of people, about 250 million. They weren't Indians. They were Purépecha, Otomi, Chumash, Araucano. They were not Indians. But the next day, October 12th, 1492, Columbus is trying to find a way to India. He sees land. Oh, I've discovered India. He looks at folks and says, well, if I'm in India, you guys must be Indians. And we've been having confusion ever since day one. Okay, Indians. Indigenous, we can use other terms. So clearly that's part of the racial narrative of the Western Hemisphere. I'm even going to say the rest. The U.S. is part of it, whether it likes it or not. To that, we add the African. There were Africans with Cortez as soldiers. Later, Africans were brought as slaves all over Latin America. And that's been kind of dropped out of Latin American history, but now it's starting to come back. Finally, for the first time, the Mexican census wants to try to figure out, well, how many Afro-Mexicans are there? Well, what question do we ask? Are you Prieto? Are you Negro? Are you Moreno? Just how do you operationalize Afro-Mexican? Peru has had a long Afro-Peruano music, food, etc. You know, even Argentina, that likes to think itself as a little piece of Europe and Latin America. I've seen the census as 1820 census of Buenos Aires, 25% of the population was African origin. Oh, what happened to them? Did they move away? No. And now, even Argentina is beginning to realize, oh, I guess we do have African roots. It gets better. Asian. Starting with the first treasure fleet that sailed from Acapulco to Manila and then back on the Japan current. And for the next 300 years, people from China, India, Japan, Malaysia, the Philippines, all over, they did have to be Christians. That was the one requirement. Flowed into the New World. So we have indigenous, African, Asian, and of course Iberian. But Iberians are also a little bit different from the British in that you'd had a long Jewish settlement there, about 2,000 years at that point. And they all got kicked out of Spain in 1492. And many of them came to the New World. And King Ferdinand and Queen Isabella were so happy. Well, look, we kicked all the Jews out. Now let's kick all the Muslims out 10 years later, and they did that. And many of them came to the New World. So they all came to the Western Hemisphere, met each other, paired up, and had kids. For example, a child of a Spaniard and Indian was a mestizo, or between an African and Spanish was a mulatto. So we're getting all these combinations to produce what I call, again, this is my term, Indo-Afro-Oriento-Ibero-America. Well, if you say Spanish America, that's just Spain, right? Let's get everybody in. All the great-grandmothers and grandfathers and everything else. There's just a tremendous amount of mestizaje, as it's called in Spanish. The Spanish crown tried to put some order to this. This is one of many. This is a 16-way table. Depending on what proportion of Indian, African, Asian, or Iberian you might happen to be or claim or be seen as, it was pretty fuzzy-edged. Oh, but we were conquered by the United States in 1848, and out came the Census Enumerator in 1850. And he's got to define everybody's race. How do you define the race of a Mexican? Well, here are instructions to the enumerator for the 1930 census. Now just listen to the code bias in this. Practically all Mexican laborers, see already, oh, you're a laborer, you're Mexican, you got to be a laborer, okay, are of a racial mixture, difficult to classify, though usually well recognized in the localities where they are found. So I thought, okay, what was going on in the 1930 census? So we have a census taker. So he's out there taking censuses. If you see somebody at the back table, can't quite figure out who this person is at the back table. So he goes over to good old Billy Bob. Billy Bob. Ism. Billy Bob. Is he a Mexican? Yep, them's Jose. He's Mexican. Oh! And thus he enters the data field as a Mexican. Science or the local racial narrative being operationalized? Clearly it's the local racial narrative. What's the science behind this? So let's look at the census, which is not science, but at least it's standardized. A Hispanic is a person of Cuban, Mexican, Puerto Rican, South or Central American or other Spanish culture or origin, regardless of race. Try using this as an exclusion or inclusion criteria for randomized clinical trial. You want to make sure you only have white people here, only black people here, and only Hispanics here. Well, we know between white and black, in theory, you're operationalized. Is there one drop of black blood? Then you're over here. If there's not, you're over here. Then Hispanic is what? And what are we comparing? Okay. After that definition, then the census asked in the 2010 census, are you Hispanic? And if you said, no, I am not, then you skip over to the next question. But if you said, yes, I am, then you had to specify. Well, I'm Mexican, or Mexican-American, Chicano, or I'm Puerto Rican, or I'm Cuban, or I'm some other Spanish, Hispanic, Latino. You know, when you start creating items for questionnaires, the cardinal sin is to ask two questions in one. Like asking, is today Tuesday and will the Boston Red Sox win the championship? Well, wait a minute, ask me one or the other, right? You should only ask one question per item. Already, even just the last one, are you Spanish or Hispanic or Latino? Well, what's the difference? Doesn't matter, just answer, pick one. Okay, so you pick these. Oh, by the way, what race are you? And Latinos look at that. Well, I'm a little bit white, I'm a little bit black, I'm a little bit Indian, I'm a little bit, some of these somewhere from Asia, maybe a little bit Hawaiian, but what do you mean pick one of these? So let's look at how Latinos answered the question on race in the 2010 census. Well, about half said they were white, and close to half said, I'm not just white or black or Asian or Indian. I must be some other race, or I'm two or more races. That's almost half. Remember, in the non-Hispanic, that was like 2.5%. Here, it's almost half. And by the way, when Latinos say, oh, I'm white, they don't mean it in the way the Aryan nations mean it necessarily. It could mean I'm an American citizen. It could mean I'm middle class. You know, Aryan nations isn't going to accept that. So let's actually look at the 1,000 Genomes Project. As they're taking these genetic sampling, here, Colombians from Medellin, Puerto Ricans from Puerto Rico, and Mexicanos in Los Angeles. And the way you read this is that the yellow is Native American, blue is West African, and red is European. And you will notice, by the one-drop rule, 95% of Latinos should be counted in the black column by the one-drop rule, right? If one drop is that powerful, that's all it takes, then Latinos should be in the black column in terms of mortality, this and that, the other. And if we did that, and we looked at those linear regressions and all those black points, it'd suddenly be down where we see Latino, and there'd be no African-American infant mortality problem. Problem solved. Only on paper. We would have an on-the-street issue. This, by the way, is a photograph of the last Mexican governor of California, Pio Pico. As you look at this photograph, clearly he's of African and indigenous origin, probably a little Iberian in there. In fact, I looked up the 1790 census when his grandmother and all his uncles were listed as mulattoes. Clearly, he is not white. But thanks to the California Constitution, he was a citizen, and he voted for the next 44 years until he died. If he'd ever gone to Mississippi, he was property. Okay, so let's go back to this. A person of mixed white and Negro blood was to be returned as Negro no matter how small the percentage of Negro blood. That is the hard-edged binary. And we use it, so we have these racial groups, but then we got this crazy Hispanic regardless of race. It is so important between here and here and here, and suddenly it's not important. Then what are we comparing? What are we comparing when we do this? Please. Are we scientists or are we not? I get people upset at me. What do you mean ask? Everybody does this. It's blah, blah, blah. I don't care if everybody does this. I want an answer. So we're getting one in the form of California's racially ambiguous babies. I don't know if you ever read Thomas Kuhn's Structure of Scientific Revolutions. Got to see how much time. Ooh, I got to start winding up here. We're getting to the crisis stage. The crisis being, in Kuhn, when you have normal science, all the researchers agree on certain paradigms in the data and everything's fine. You're just going to iron out a few wrinkles, you know everything in the world. But then some people notice little anomalous observations that don't fit. And as the number of observations grow and grow until finally they can't be ignored, that's when you get to the crisis stage. California's racially ambiguous babies are pushing our standard narrative to the crisis stage. So under the hard-edged category, the way we do this, by the way, how we can get everybody into one column, is that at least in California, and this varies by state, we assign the race of the mother to the baby. So here we have, when we do that, everybody falls niftily, well, except for about 11%, babies into their categories. Looks nifty, doesn't it? But what we are doing is using the American Community Survey, the Census data, and we're going to add in the fathers. It does take two to tango and make a baby, right? Okay, this is the race of the mother. So what we're going to look at the race of the fathers, the cases where they are racially congruent, both mother and father are of the same race group, and the non-congruent, where they are of different race ethnic groups, and it looks like this. Yeah. Okay. So if you have here this percentage, the mom's white, the father is not. Could be an Asian, African American, Latino, whatever else. Where do you record the birth weight of that baby for scientific purposes? I know, we would, in California, oh, that baby's white, so we're going to put the birth weight here. In other states, oh no, the father's black, we're going to put it with the father. And then there's a third rule, it's called hypodescent. Whichever is the most non-white, that's what we'll assign. And of course, the nifty thing is we have the birth certificates don't ask the race of Hispanics. You're just Hispanic, remember? But the census does ask the race question. Latinos do respond. So here we have a lot of Latinos who are some other race. So welcome to the fuzzy-edged Latino multivalent racial narrative. If we just collapse the babies, 47% had same single race parents. 52.6% are ambiguous. Their parents are of different race ethnic groups. That will be 250,000 babies every year. Where do we record the birth weight? White, black, Asian, Indian, Hispanic, whatever that is. Here's how we got there. Of all babies born in California, 25% the mothers and fathers were of different white, black, Asian, Indian groups. Another 16%, the mother or the father said, I don't know what race I am, or sometimes both. And under what column do you record the ones who said, I don't know what race I am? I don't relate to that. 8% gave no information. And 3.5% already said 1, 2, or more races. How do we record the birth outcomes? Later track the infant mortality. How do we know where there are health issues? And millennials increasingly are reluctant to identify themselves by the standard racial groupings. In this particular story, This individual, depending on who was asking her, Department of Education, National Center for Health Statistics, the Census, et cetera, could fall in all these different categories because she is multivalent. We need to understand how to use multivalence in tracking health disparities. And Latinos bring in some new terms. Most Latinos do not say they're Indian. They got the message. I can't say I'm an Indian in the United States because I have to be enrolled with a tribe that's recognized. Well, my parents are from Oaxaca. They speak Zapotec, but I guess I'm not an Indian. No, you're not. But they do call themselves indigenous. About a quarter. Didn't say they were black, but they do say I'm Afro-Latino. And also, Latinos use mestizo, mulatto, to describe themselves. So, just in the issue of race, we have code bias. There's the hard-edged U.S. binary that just absolutely demands you must be here or there and nothing in between. That's how we get these tables. Or maybe we need to start to explore this fuzzy-edged Latino multivalent that will figure out how do we track infant mortality and birth weights when the baby's parents look like this. I haven't got an answer, by the way. I'm posing the research question. Because it turns out the issues of race, ethnicity are very intersectional. They're very situational. It depends when. And very intentional. What's the individual's intention in all of this? And we don't capture that. Well, are you this race or that race? So let me just wind up. What we're doing in our project, we're trying to find metrics that really do measure health disparities and predict outcomes without using the race-ethnic categories as we currently know and love them. I don't have an answer. That's our research question. However, we figure rather than talking about race, we ought to talk about racial narratives and how we talk about health, how we legislate about race, how we legislate about race. Maybe that's what's having the impact as opposed to an innate individual characteristic. It's the narrative about race. And we also need to research community agency in contesting the racial narrative. What time do I have to stop? Got one more slide. Okay. So here we are trying to research the racial narrative, and here's sort of where our thinking is right now. That there are 4 domains of the racial narrative that I would like to know more about. First domain is what I call, and these are all my terms, foundational state violence. In order for this country to be founded, some racial groups suffered tremendously. American Indians, well, we took their lands. African Americans, we stole their labor. And Mexicans and Puerto Ricans, by the way, we took over their land too and tried to legislate them out of existence. That's one level of violence that no other groups had to deal with so that this country could be founded. Well, there's other violence. There's state aggression. We've been muxing around in Central America and Latin America for a century and a half. We were in Vietnam. That's why we have so many Vietnamese here. You know, wherever we fight wars, we wind up having refugees from those areas. You know, Afghanistan, Iraq, etc. Then there's state discrimination. That's when the power of the state draws these racial lines. The power of the state. Then there's social discrimination. It doesn't have the power of the state, but it's the social norm, the social mores. So right now we're thinking these are different domains. They probably have differential effects. They all have some effect, and they could interact with one another. And we're trying to figure out, how do we operationalize this? How do we? I don't have any answers. That's why I'm a researcher. That's why I'm a nerd. But we have some anomalous observations we want to follow up with. So yes, biomedical research does need diversity. You're going to hear all about this. Diversity is wonderful. Don't get me wrong. I think it's great. But that diversity needs to have voice. And that voice comes out of your lived experience, individually and as a community. So that next generation, when we're developing these neural networks, that other 62% of California that has different experience with the U.S. racial narrative also says, oh, here's the world I grew up in, and put that in front of the neural network. And maybe we'll get better facial recognition programs, which is why we need your voice in health research. Oh, by the way, owning this. Okay, I finally owned, I'm 8th generation American of Mexican origin. I don't care what the hell you think. I was here before you were. But I go to Mexico, and I give a talk like this one. It's TEDx. So I come out, first thing I say, soy Chicano. I'm a Chicano. And people kind of titter a little. Oh, you're not supposed to say that, you know. Saying Chicano in Mexico, I say I'm a juvenile delinquent. Okay, but I'm a Chicano, what can I say? Then I say, y no es que hable mal el español. It's not that I speak horrible Spanish, sino hablo pocho. I speak Spanglish. Y hablo un pocho perfecto, and I speak perfect Spanglish. Let's go. And yeah, it's over. Okay. Thank you very much.